with the aim of talking about strategies to improve the screening for cesarean scar pregnancies and placenta-accreted spectrum disorders, especially in the settings of low and middle-income countries. So first question that I need to ask is, are these screening programs in low and middle-income countries working well? And the answer, unfortunately, is no. As we can see here from this brilliant paper done in Latin American settings and encompassing 52 cases of maternal deaths due to placenta-accreted spectrum disorders, we can see that the reasons for these patients dying are related, around 50% of them not reaching specialized multidisciplinary treatment centers. And among the reasons for them not reaching these specialized centers, almost half of these patients did not have the opportunity of having the prenatal ultrasound diagnosis of placenta-accreted spectrum disorders. So unfortunately, it is not working, but is it possible to improve this setting to better screen for CSP and PAS in low and middle income countries? And I have to say that the answer is, of course, yes, but it will take some effort from not only from the healthcare providers, but also from the stakeholders involved. So this presentation has the aim of trying to tackle this challenge and to improve this screening performance. But firstly, we have to decide which battle to choose. And I would like to say that we should aim for the screening and for diagnosis of only the clinically significant placenta-accreted spectrum disorders. We should try to avoid those false positive cases reported by Professor Janio in the last discussion, such as the difficult placenta removal that we usually tackle with courage after the delivery. We are in this for a better performance of the screening program, we should aim on the clinically significant placenta-accreted spectrum disorders that are those cases with higher morbidity, where the placenta does not separate spontaneously from the uterus, especially because it is located in those regions of the lower uterine segment, especially in the anterior or the lateral part, close to important pelvic organs such as the bladder or the parametrium, and all those vascular structures where there is difficulty to perform a definitive treatment. And so when should we think about CSP and placenta-accreted spectrum disorders? When we see the literature, we see that a lot of risk factors have been associated with placenta-accreted spectrum disorders. And in fact, when we look in a univariate analysis, lots of these risk factors here presented, they can be related or associated with placenta-accreted spectrum in the second or third trimester. But when we perform a multivariable logistic regression analysis, the risk factors that we can see that are individually related, associated with placenta-accreted spectrum disorders are mainly two: a previous cesarean section, as previously mentioned by Professor Ilan Timur-Trich, but also the position of that placenta covering the internal was a placenta previa or a low-lying placenta, especially in the anterior aspect of the lower uterine segment. So to summarize, these are the main risk factors for placenta-accreted spectrum disorders: the low-lying or placenta previa and a previous uterine surgery. And in more than 95% of cases, we are going to see these PAS cases occurring after previous C-sections and more rarely after other uterine surgeries. So after choosing this battle, now it's important to raise awareness about this condition. We saw that cesarean scar pregnancies are probably, the incidence is probably between 1.5 thousand to 2.5 thousand previous cesarean cases. And we know that it is related to previous cesarean section. So we have to raise awareness, not only of the lay population, talking about the benefits of doing a vaginal delivery and avoiding an unnecessary primary cesarean section, but also of our colleagues that are taking care of the antenatal care of these pregnant women, and also people that are going to do the imaging studies of these patients. But are we worried about it? It seems that in countries like Brazil, we are not too worried about it. And Professor Berghella told us about the increasing rates and probably increasing trend in cesarean sections that are going to occur in the next years. And in Brazil, this is already a reality. Since 2009, we have more pregnancies being resolved by C-sections than vaginal deliveries. And nowadays we have almost 60% of our deliveries here in Brazil being resolved by cesarean section, what is a shame. And we know that the more cesarean sections we do, the more placenta criti spectrums we are going to have. And in countries like Brazil, it can be 1 in 500 cases almost. And as previous presenters have told us, this has the increasing rate of cesarean sections has occurred during the last 30 years, and there is a trend in all regions of the world for an increased rate of cesarean sections in the next 10 years, especially in places like Brazil, middle-income countries, where this problem is already high. So what happens? What usually happens? Why our performances, our screening program performances are not good? Well, because this is usually what happens. Let's say that tomorrow morning, 7 a.m., we are going to see our first patient. We usually receive this kind of referral here, only stating at most the gestational age that the patient has at that moment, and saying that the patient needs an obstetrical ultrasound. And then when we see an early pregnancy like that, we pay full attention to the embryo, we do the CRL, and we don't usually pay attention to the region of a previous cesarean section. This patient is going to come again to do an anatomical second trimester scan, and the same thing happens, only gestational age and the need for an obstetrical ultrasound. And it's impossible to compete the empathy of the fetus with the placenta and myometrium. We're going to pay a lot of attention in all these important anatomical aspects of the fetus. We'll do a baby face, we'll show the gender to the family. But when we are going to write our report, when we reach this field here, there is placental location. It's not surprising, and this happened a lot of time, that we at this moment we see that we haven't paid any attention to the placenta, and there is a full line of patients waiting for their next examinations. And in this moment we have to be more resilient than Jesus Christ in the desert, and to avoid the temptation of not bringing the patient back to the room and looking for the stored pictures at our equipment. And then we see that there's an image here suggesting that the placenta is anterior, and we have to avoid the temptation of writing the report and stating there that the placenta is anterior high, because 10 weeks later, what is going to happen is that this patient is going to be delivered by someone, and a situation like this can happen in the same patient that I showed you the last picture. So it's extremely important to give proper attention, not only to the placenta, not only to mind the placenta, but the underlying myometrium, as we have already learned from the first session of this course. Because if we have paid proper attention, even in the early gestational age scan, we could see aspects that would suggest a cesarean scar pregnancy disorder, or later in pregnancy, a placenta accreta spectrum disorder. So once again, I urge you to pay proper attention, not only to the placenta, but also to the underlying myometrium signs for CSP and PIS at every ultrasound examination. And one thing that might help the sonologists, the sonographers, to pay proper attention to this is the primary care setting professionals to write that the patient, to ask or to do a good anamnesis, a good interview with the patient, to observe that the patient has a previous cesarean section or a previous uterine surgery, and ask for a detailed report of the placental site and aspects of placenta accreta spectrum, or CSP. And still in the raising awareness issue, I would like to commend and to thank SWOG for almost doing a course every year. In all SWOG congresses, we have placental anomalies sessions, and placenta accreta spectrum disorders are always addressed. In Brazil, we have recently created a Brazilian network for studies of placenta accreta spectrum. We are trying to do monthly sessions with colleagues like Álvaro Nieto Calbate. Our journals are trying to increase publications about placenta accreta spectrum disorders and the problem of the higher incidence of cesarean sections in Brazil, and what to do to prevent these problems. So we have to raise awareness of this condition. Without raising the awareness, we will not have a successful program. But then, after raising awareness, next step is to make an action plan. We have to try to establish, to set up a referral pathway for these patients to avoid morbidity and mortality related to CSP and PISs. And this starts, once again, in the primary setting. People looking for early pregnancy, they should do a good clinical interview. They should know if the patient has a previous uterine surgery, and if the first ultrasound shows that the placenta is located in the lower anterior segment, these patients have a positive screening. And this positive screening should start a referral for a specialist fetal medicine team, where this fetal medicine specialist is going to confirm or to exclude that possibility of having a CSP or a PIS. And if the diagnosis is excluded, that this patient can be safely referred to the local practice. But if there is a high suspicion for CSP or PIS, this patient should be referred for a multidisciplinary team, a specialist PIS referral center, for a better management of that case. And how should we plan to do or to start this screening program? We have 3 gestational ages that we should try to aim to look for CSP and placenta accreta spectrum disorders. And it starts, as Professor Ilian said before and published before, it starts early in pregnancy, especially in the period between 5 and 7 weeks of pregnancy, before 9 weeks of pregnancy. And this is not only because it is easier to diagnose cesarean scar pregnancies early in pregnancy, when they are intrinsically related to the scar. Placentas are implanted over or into that scar, and it's easier to see at that moment. But also because treatment is better. The treatment is safer when it is performed before 9 weeks of pregnancy, as this publication has previously addressed. So we should always try to perform an early scan below 9 weeks, between 5 and 7 weeks, to try to observe if there are signs of a cesarean scar pregnancy, if a patient has a previous cesarean section. Although This is not a reality in many places of the world. I would say that in low and middle income countries, in some places, in Brazil, for instance, low-risk pregnancies usually have one ultrasound during pregnancy, and this ultrasound will obviously not be done in the early gestation. It is going to be done later in pregnancy, usually in the second trimester. So we have to know how to deal with these situations in two other periods. In the period of first trimester screening, 11 to 14 weeks of pregnancy, as advocated by the Fetal Medicine Foundation, or if we see a patient in the second or third trimester of pregnancy, there is another strategy, contingent screening program that we can use, light advocated by St. George's University of London. And what's the difference between one and another? As we can see here, when we're seeing this patient in the first trimester, we have to ask both questions to the patient. Is the placenta low-lying or previa at this stage of pregnancy? And does the patient has a previous cesarean section? If the answer is yes to both questions, this patient is going to be referred to a specialized antenatal clinic for the confirmation of this diagnosis. And when we see these patients, according to the St. George's scheme here program, when we see these patients for the anatomy, second trimester anatomy scan between 18 and 24 weeks of pregnancy, at this point, we should do a screening for placenta previa. Okay, so we should only pay attention here at this moment if placenta is low-lying or previa. And if yes, this patient needs to be referred once again at the beginning of the third trimester for another evaluation, when we will ask both questions. Is the placenta still low-lying? It's a persistent placenta previa or low-lying placenta. And if yes, has the patient a previous uterine surgery, a previous cesarean section in most cases? Yes. If the answer is yes, then the patient is going to be referred. Why? What is the uptake of both screening strategies? By doing it in the first trimester, 6% of patients are going to be referred to the specialized clinic, whereas if you are doing the second plus third trimester contingent screening strategy, only 0.1% of patients are going to be referred to the specialized center. What means that if you use the first trimester screening strategy, you are going for every 100 patients you refer to the specialized clinic, one is going to be a placenta criti spectrum disorders. On the other hand, for every 3 patients that you refer to the specialized clinic, one will be a placenta criti spectrum disorder in the second contingent screening strategy. So this strategy is better for diagnosing and managing cesarean scar pregnancies. And of course, at every opportunity, we have to look for signs, especially if the patient has both risk factors. On the other hand, if we are talking about low-income countries, if the patient is going to have her first ultrasound examination at 20 weeks of gestation, we have to take this opportunity and use the second screening strategy. As Professor Ilan has previously shown, this strategy, the second strategy, has a good accuracy, and it relies on 2 simple questions. Asking if the placenta is low-lying and if it is persistent in the third trimester, and knowing if the patient has a previous C-section. In Ribeirão Preto, in Brazil, my country and my city, we do we have a similar approach. The only thing, of course, if the placenta is low-lying or previa, the patient comes to our clinic and we ask if the patient has a previous C-section, but we also expanded the screening strategy for patients with previous cesarean sections and anterior placentas. Why did we do that? Because unfortunately, screening for placenta previa and low-lying placenta in Brazil is not done routinely. So we expanded. These patients are triaged in the screening unit, and if there are and if the placenta is high, not related to previous cesarean sections, we usually reassess these patients. And if no signs, or if there's low risk for placenta criti spectrum disorders, they are going to usual C-section or vaginal delivery setup. If we have suspicion of placenta criti spectrum, then multidisciplinary treatment approach is performed for these patients. after we started this protocol in 2014, you can see here that the number of unexpected cases in black here reduced a lot. And in fact, there is in 7 years, we haven't had any unexpected case in our center for patients that are delivering in our unit. And lastly, I would like to say that for countries like Brazil or for rural states in developed countries, telemedicine can be a good help in stratifying which patients need or need not go to a multidisciplinary specialist hospital. We are trying to start this in Brazil using not fancy technology, but we're using WhatsApp calls and trying to guide people who are doing ultrasound on what plans we need to observe. And in many cases, we can see that it's not a real case. As we raise awareness, there are more false positive cases of placenta critical spectrum disorders, and some of these cases can be managed safely and locally. I would like to finish my presentation saying that although we are talking about CSPs and PASs, there are other disorders related to previous cesarean sections, such as isthmoseals. All of them can lead to adverse outcomes, but paying proper attention to the placenta and underlying myometrium, we can make this diagnosis by using ultrasound during pregnancy. Thank you very much, and I would like to leave here some take-home messages, increasing awareness not only of the population about the need for more, for avoiding unnecessary cesarean sections, remembering our colleagues on the primary setting to make proper referrals for imaging professionals, and to pay attention for the local placental implantation, and pay attention for the 2 risk factors that regarding a screening program are the most important: low-lying placenta previa and previous cesarean sections. Thank you very much for